السلام عليكم ورحمة الله وبركاته. And this lecture regarding congenital anomalies, second part. In this part, we discuss chromosomal and genetic factors with testing and diagnosis of fetus or embryo. Starting with chromosomal and genetic factors. As I mentioned in the lecture of gametogenesis, a lot of chromosomal abnormalities may occur, and these chromosomal abnormalities may be numerical or structural. Numerical, that means we have uh, unusual or unequal number of daughter cells in chromosomes, and it may be structural, that means the structure of chromosome have a defect, but the number it's right and no any faulty numbering in chromosomes. The important causes of congenital malformation and spontaneous abortion, because it's estimated about 50% of all conception in spontaneous abortion, and 50% of these have major chromosomal anomalies. The most common chromosomal anomalies or abnormalities in aborted fetus is Turner syndrome, triploidy, and trisomy 16. The factors or genetic factors may be numerical abnormalities or structural abnormalities or mutant genes. Starting with numerical abnormalities. Normally, the gametes are haploid. That means the number of chromosomes in each gamete are equal to 23, while the normal human somatic cells contain 46 chromosomes, which are diploid or 2n. So we have here a term euploid. Euploid, that means each multiple of n. Also we have the term aneuploid. Aneuploid, that means chromosome number is non-euploid. That means it may either additional chromosome or missing chromosomes. The most cause of this numerical abnormalities is non-disjunction during either meiosis or mitosis, while the risk of meiotic non-disjunction is increased with increasing of maternal age. Here, the cell division and result in two cells. And the normal, they have unequal chromosomes here and here. But in case of one of the cells having missing, it's called monosomy, or having additional, it's called trisomy. Starting with the trisomy, the most famous trisomy is Down syndrome. It's trisomy in chromosome number 21, which have an extra copy of chromosome 21 in 95% of fetuses. In this case, it's related to growth retardation, vary degrees of mental retardation, craniofacial abnormalities including upward slanting eyes, epicanthal folds, flattened face, small ears, with cardiac defect and hypotonia. The most of the time due to meiotic non-disjunction. That is increase the risk where the woman's age more than 35, which occur in 1 of 1000. But this decrease in 1 to 40 in women under 35. This karyotyping showing the trisomy on chromosome number 21 and Down syndrome. And these are the features of Down syndrome. Also, we have trisomy 18 associated with mental retardation, congenital heart defect, lower set ears, flexion of fingers and hand, microdysplasia, renal anomalies, syndactyly, malformation of skeletal system, and actually the infant usually die by age of 2 months. The incidence of trisomy 18 around single case in every 5,000 fetuses. This karyotype showing the trisomy 18. The total number of chromosomes 747. And here is the female XX, the extra copy on chromosome number 18. This is a feature of trisomy 18. Prominent occiput, cleft lip, microdysplasia, lower set ears, and more flexed fingers. Also, we have trisomy 13 associated with mental retardation, holoprosencephaly, congenital heart defect, deafness, cleft lip and palate, eye defects including microphthalmia, anophthalmia, glaucoma. And most the infants actually die by age 3 months. The incidence of trisomy 13 is around 1 case in every 15,000 fetuses. And this karyotype of female showing additional copy of chromosome number 13. And here, this figure showing the child with trisomy 13 with noted cleft lip and palate and sloping forehead, microphthalmia, and the case commonly accompanied by polydactyly. You can see here around 6 fingers there and there. Also, the trisomy, if occur in 6 chromosome, it may lead to Klinefelter syndrome. It's found only in males. The result 47 chromosome with additional 6 chromosome XXY. It's the most common feature. Usually detected at puberty. It occurs in 1 versus 500 male. It's due to non-disjunction of XX homologous chromosome. It's commonly accompanied by sterility, testicular atrophy, hyalinization of seminiferous tubules, gynecomastia, and maybe some degree of mental impairment. Also, it's increased with increase of number of X chromosomes. Example, it may be 48 chromosome by the mean of XXXY. And this figure showing the Klinefelter syndrome. The first diagram showing normal oocyte with sperm carrying XY chromosomes. Or maybe the opposite. The oocyte with XX with sperm with Y chromosome. And this karyotype showing the 6 chromosome additional number. Here we have XX and extra copy of Y chromosome. The features of Klinefelter syndrome including small testes, female hairy pubic type, tall stature, slightly feminized physical status, or mildly impaired IQ, less than 15 point, tendency to lose chest hair, osteoporosis, breast development in about 30% of cases, poor beard growth, and frontal baldness of male feature is absent. Second type of numerical anomaly is Turner syndrome, which complete the figure of Klinefelter syndrome. In Klinefelter syndrome, we have additional 6 chromosomes. In Turner syndrome, we have a missing chromosome, which is found in women with unmistakably female appearance and is associated with absence of ovaries, bigonadal dysgenesis, short stature, webbed neck, lymphedema of extremities, skeletal deformities, broad chest and widely spaced nipple, and usually missing one X chromosome. So we have 45 chromosome with missing X chromosome. And this karyotype showing the features of karyotype regarding Turner syndrome. Here we have a loss of the second X chromosome. And the features of the Turner syndrome including low hairlines, short stature, cardiac defects, uh, widely spaced nipple, shortened metacarpal, small fingers, nail, brown spot in the body, no menstruation, rudimentary ovaries, or ovarian dysgenesis, elbow deformity, poor breast development, folding of skin, constriction of aorta. Another numerical anomaly or abnormality is triple X syndrome. That means we have XXX chromosomes. The patients with X or triple X chromosome abnormalities are infantile with scanty means and they have some degree of mental retardation. That is regarding the main numerical abnormalities. Shifting to structural abnormalities, which may involve one or more chromosomes, it usually results from chromosomal break. So the broken pieces may be lost or may be added to other chromosomes. Also, we have a deletion. Deletion that means the broken piece lost. The most common deletion deformity or abnormality is a partial deletion of chromosome number 5. In case called Cry-Duchat syndrome, it's associated with microcephaly, mental retardation, and congenital heart disease. Also, many other relatively rare syndromes result from partial chromosomal loss, but the most common in chromosomal loss is deletion of chromosome number 5. And this karyotype showing the Cry-Duchat feature, and here is chromosome number 5. We have deleted part of the chromosome, and it could be severe in around 78% of chromosome, and it may be mild in around 22 of cells. Microdeletion also may be occur and span a few contiguous genes like aka contiguous gene complex can be identified with high resolution chromosome binding technique and genomic imprinting. This case exhibit differential expression depending if the gene material is from mother or the father. It's different if the source from paternal or maternal. Starting with deletion of long arm of chromosome number 15, We have two variety. In maternal organ, if the deletion occur in chromosome number 15 with maternal organ, it's called Angelman syndrome. Associated with mental retardation, difficulty in speaking or cannot speak, exhibit poor motor development, and prone to unprovoked and prolonged period of laughing. If the source is paternal from the mother, it's called brother Willie syndrome, associated with hypotonia, obesity, mental retardation, hypogonadism, and cryptorchidism. So the deletion occurs in single chromosome, chromosome number 15, but different if it affects maternal chromosome or paternal chromosome. Here is a figure of Angelman syndrome resulting from micro deletion of maternal chromosome 15. So it's inherited on the paternal chromosome, Prader-Willi syndrome in this figure. This is Prader-Willi syndrome from paternal microdeletion of chromosome number 15. Fragile site regarding structural abnormalities, the region of chromosomes that demonstrate a propensity to separate or break under certain conditions. For example, Fragile X syndrome, which associated with mental retardation, large ears, prominent jaw, pale blue iris. In males occur around 4 in every 2,000 fetuses. In female occur in 1 on 4,000 fetuses. It's second to Down syndrome as a cause of chromosomal driven mental retardation. Regarding mutant genes, many congenital malformations are inherited. Some show a clear Mendelian pattern of inheritance. In many cases, abnormalities attributed to change in structure or function of a single gene. It's called here single gene mutation. Estimated that this type of defect make up about 8% of all human malformation, which may be dominant or recessive or X-linked, which also recessive. That is regarding chromosomal and genetic abnormalities. Regarding prenatal diagnosis, we have prenatal screening and diagnosis test. Screening test performed in all women to identify those at risk of disorder. Screening also do not confer any risk to the pregnancy, while the diagnostic test carried out only on a pregnancy at high risk of a disorder. Also, diagnostic tests usually invasive and carry small risk of miscarriage. Starting with ultrasound and used as screening test. It's guide for other diagnostic tests like amniocentesis, chorion villus sampling, or chordosynthesis. It's used separately as a screening test and it aids in diagnostic tests like amniocentesis or chorion villus sampling and chordosynthesis. Here, ultrasound cannot see nuchal translucency, and here it's indicated to abnormalities if increased nuchal translucency. Also, we can screen for hydrocephalus like this figure. Invasive diagnostic tests including amniocentesis, chorion villus sampling, and chordosynthesis. The sample obtained is used for cytogenetic or DNA analysis to give a prenatal diagnosis. These tests are invasive and carry small amount of risk of pregnancy miscarriage. Starting with amniocentesis performed under ultrasound guidance, so the fluid aspired and removed containing fetal fibroblast and performed after 15th week of gestation. The risk of miscarriage is around 1%. Here's amniocentesis guided by ultrasound, and here we aspire or withdraw a little fluid or amniotic fluid. Chorion villus sampling also performed under ultrasound guidance. The sample aspirated contained chorionic villi and performed after 10th week of gestation, and the incidence of miscarriage rate regarding this diagnostic test about 2%. And here is chorionic villus sampling, maybe either transabdominal or bare vaginal. The two procedures should be guided by ultrasound. Choreocentesis also performed under ultrasound guidance. A blood sample contained or obtained from umbilical cord, and this performed after 20 weeks of development. The rate of miscarriage is around 1%. Key points regarding screening and test. Overall prevalence of congenital anomalies is about 2%. So the tests for the fetal abnormality fall into two groups, screening or diagnostic. A number of tests exist to sample material of fetal origin that may be diagnostic. Generally, these tests are invasive in nature and carry small risk of miscarriage, not more than 3%. The ultrasound play a major role in screening, and preconceptual foliate reduce the risk of developing neural tube defects. However, individual risk is predicted based on maternal age, gestational age, and variation of hormones levels, mainly alpha-fetoprotein and human chorionic gonadotropin, AFP, alpha-fetoprotein, HCG, human chorionic gonadotropin. Sonography measurement of nuchal translucency at 11 to 14 weeks of gestation offer another approach to screening for defects. So, this is the last lecture regarding embryology aspect of growth and development. I hope you enjoyed these lectures, and I'm pleased if any question or any point need clarification. Feel free to contact me via Telegram. Send your questions. I'm going to answer you, as I mentioned, every lecture. So, thank you and good luck.